I'm Denis Walsh. I'm Associate Professor of Midwifery at Nottingham University. Been a midwife coming up 30 years now. Sort of in practice for 15 or so, and then in the more academic area of research. So I'm kind of heading towards flexible retirement now. But my current involvement is around midwifery unit research. Yeah, and I'm a father of 2 daughters.
Is home birth safe?
You know, we've had loads of research over 40 years now about it to suggest that there isn't any problem for babies with home birth. So all different countries, different size of populations, mostly studies that look back rather than forward, because from a point of view of what's evidence, looking forward is better in terms of the method of doing it, but it's quite difficult to do any sort of comparison. But the studies that have been done are very reassuring. There's only one, that was one in the UK, 2010, that suggested slightly poorer outcome for babies in first birth women at home.
Yeah.
But actually, if you unpack that a bit, you can probably look for reasons why that might be the case. So all the other studies said it was safe for women, to birth at home of any first, second, third baby, different countries.
Right.
So it's really very reassuring.
Right. Any provisos around that? You mentioned if it was a first baby?
Yeah, I mean, this study showed that the babies had a slightly poorer outcome, but it was quite a tiny difference. So if I give you a few figures that might help a bit, 5 in 1,000 babies in any birth setting get sick or might die on that sort of spectrum. In this study, 9 out of 1,000 of women having their first babies at home.
Oh.
Yeah, got sick.
So 5 out of 1,000 with a second baby,
yep.
9 out of 1,000 with a first baby.
Yeah.
So the difference is...
Small.
And when we say poor outcome, it's not all those babies are dying.
No, it's not. It was just things like a little birth injury, admission to the special care baby unit, a little bit of breathing difficulty, that kind of thing. So they were all lumped together.
Okay. And this is home?
Yeah.
Okay.
Yeah.
Brilliant.
Yeah.
Right, Denis, another thing that comes up amongst the men and the couples that I work with is this question: what can I do if we want a home birth, but our doctor or midwife is saying no?
Yeah. Well, a part of me would like to think that's not going to happen much these days.
Right.
There's a couple of reasons. One is that general practitioners are not so involved, at least in the UK, with women when they're first pregnant.
Right.
The recommendation is you see a midwife. But it might happen. Essentially, a GP can't deny you a home birth. He's not providing that service.
Right.
So if that happened, I'd just ask to see the local midwife.
Right.
And
okay.
just bypass
what if the doctor's an obstetrician?
Yeah, I mean, again, in theory, they shouldn't be discouraging if the woman's normal and hasn't got any background illness. But if she is, if they are saying that, then again, I just ask for a midwife. It gets trickier if you're asking an NHS midwife, so the ones you're going to meet in normal maternity care, who's discouraging. I can see why a couple might be worried about that, because if she's saying that, and if she's going to be available when, in that area when your partner goes into labour, do you really want her there when she said that to you up front? I wouldn't want her there.
No.
So some people, of course, will then search out, do a bit of checking to see whether there is any areas in the local area where midwives are doing home birth, because sometimes there's little patches, may not be exactly where you live. So you might get that through just inquiring through other midwives. Eventually, you might have to try and approach an independent midwife.
Right.
Because they always provide home birth.
Yeah. And independent midwives are working outside the NHS structure.
They are working outside the NHS.
They're still fully qualified.
Absolutely, yeah. Highly trained. I mean, in some ways, they're the best because they're so familiar with home birth. They're always doing it.
Yeah.
Because the NHS provision for that has got so small. There aren't that many NHS midwives who are doing it regularly.
Right, and they're regulated by the NMC.
Yeah, they've got that, but they don't have the sort of oversight of guidelines, national guidelines stuff that we have in the NHS.
Yeah.
So they can flex around that a bit more.
Right. And independent midwife obviously costs money, so we're probably talking upwards of 3,000.
Possibly, yeah. I think they do different arrangements, don't they?
Yeah.
They're sort of flexible. You'd have to approach them and ask them,
Yeah.
you know, what...
Well, is there any compromise that might be able to be made in a discussion with midwives, NHS midwives and doctors around home birth? I mean, what other options are there?
I mean, the other options are midwifery units, or
Right.
sometimes they're called birth centres. There's two varieties of those. There's one that's called a freestanding. That's probably the closest to home birth because it tries to mimic a home birth sort of setting by being in a facility that's done up really nicely, like homes.
Like home, yeah.
Yeah, like homes might be decorated. They don't have on-site backup services like special care baby units, obstetricians do caesareans. So when you make that choice, there's a chance that a transfer during labour might be needed via ambulance. But these days, those are set up, paramedics are trained, midwives will accompany you. So the transfer is something to think about it, but it shouldn't be a disincentive really.
Right.
But yeah, they're set up with a small group of midwives. They tend to be smaller facilities, they're quite personal. Actually, their evidence base, their effectiveness for safety for mothers and babies is outstanding.
Outstanding.
Outstanding, yeah. It's in that group of women who haven't got the complications, freestanding birth centres prevent caesarean. They reduce the risk of caesarean,
Right.
so they're safer for the mother.
Right.
They're actually better for the baby, not because the outcomes vary, but because women who birth in them are more satisfied with their birth experiences.
Right.
We know that probably rubs off on their babies as well.
Yeah.
Actually, if this interests you, they're cheaper than other NHS provision. So they're cheaper than a big obstetric labour ward.
And the evidence suggests their outcomes are very, very
really good.
This is your area of expertise.
Yeah, and I was thinking about it the other day. And I thought, what's the strap line we need? Because they are under threat of closure because they're small facilities. The bigger hospitals gobble them up. And I thought my strap line would be safer for the mother, better for babies, cheaper for the NHS.
Dennis, if you were chatting to, we're talking to men today, if you were chatting to a man who had just found out that his partner was pregnant, what would be, 30 years of experience of being around birth, what would be the stuff you'd want him to know?
Well, in relation to the labour event, which is the big one really that gets into everybody's mind, especially as the pregnancy, because there's other stuff you could talk about during the pregnancy. But in relation to labour, the most important thing really is to avail yourself of some kind of education around it. And there's some really good resources around now to help with that.
Yeah.
So that's about just getting educated as to the process, but also finding out ways of being in labour that can help you with, say, the contractions and all of that stuff. Yeah. So, we've actually got pretty good evidence that joining a group of other women, and that's the way it normally kind of works, you join another small group of women who are in the same situation, builds a lot of solidarity and mutual understanding. The education's really helpful. The partner involvement is critical because, if they're going to be the companion of choice, when these days most of the time they are, then they certainly need that education.
98% fathers are present.
Yeah, 98, yeah. So it's as important, almost kind of more important, but as important as the mother, as the woman having access to some of that education.
Yeah.
And the good packages of education, there's lots of it out there, but you've probably heard words like hypnobirthing, NCT. There's a whole range of them.
Yeah.
Okay, they may vary a bit in quality, but mostly they're singing from the same hymn sheet, and their starting point is to say, physiologically, evolutionary, we were made to birth as human beings. Yeah. So let's start off by trusting that process. Yeah. Let's find out how our body works, how our minds work, and all that kind of stuff. So build up a confidence.
So encourage your partner to be involved with that kind of program.
Yeah.
Go along yourself.
Yeah, absolutely. Go along.
And
yourself.
Of course, the men are listening to this on the Birthing for Blokes program, which has been designed for them specifically.
Yeah.
So do the exercises,
absolutely,
and have the experience to prepare you for that moment.
Yeah, definitely.
What else then? So get educated.
Yeah, I mean, one of the really tricky areas that focuses a lot of the midwives and obstetricians' mind is, what about that group of women who do get some complications and things don't go really according to plan? So what we know from research, I can give you the research on this, if you look forward positively to an event, you do better, basically. That's what all the research tells us.
Whatever the event.
Yeah, whatever the event. If you look forward positively, positive frame of mind. But you also need a kind of backup story for the possibility that it mightn't go exactly to plan. So have a think about that, about what options might be available. If you develop the need for, say, drugs of some kind or some other procedure, then that should be done very humanely. This is not about the birth experience changing because something new's going on and all of a sudden you're having all these things done to you. It should still be a humane process of basically caring of the companions with you, caring for you, going through that. It's still you doing the birth, remember that. Even a caesarean, you've done most of the work of the labour.
And feeling like you're making the choices.
Yeah, absolutely. But what I'm saying there is have a backup story in case that may happen.
Right.
People use different analogies, but I quite like this one because this was told to me by a woman I look after a few years back. She wanted a home water birth, so that was a particular experience. It was her first birth.
It was her preference.
Yeah, that was her preference. And she kind of described it, and it's a really common analogy of climbing a mountain. But, I wake up on the day of the climb, so the day she goes into labour, and it's really bright and sunny, and I think I'm up for this, I'm ready for this, I'll go straight up there, and get to the top, and that's my home water birth. Beautiful. But, of course, she could wake up and it's raining, the conditions are poor, she might need extra help to get up there, carry the packs, whatever, take longer to get up there, etc. But she still gets to the summit and has the baby. Now, that might be the caesarean or something like that was needed because of the circumstance.
Yeah.
So it's that kind of thing, having two stories. But, the first story is the one that you're heading towards and the one you're hoping, expecting.
I like the way you use the metaphor of story. An unfolding narrative as opposed to a plan.
Yeah, that's right. And the problem with the plan, and we use that language because you might hear the word birth plan, is that it sounds as though it's fixed, doesn't it?
Yeah. Well, if I plan to go on holiday and it doesn't go, I'm upset with it.
Yeah. So that's the kind of inbuilt flexibility bit.
Yeah. One of the exercises on the program is to spend time with your partner creating a birth preference list.
Yes.
But also, if you're this way inclined, coming up with a birth story that you would prefer.
Yeah, exactly.
So working through that narrative. And what you're suggesting is build into that story variation.
Yeah, some variations.
Because what is it? 25% of women will need some kind of support from their medical colleagues.
Yeah, that's right.
So about 25%.
Something like that.
So some of the people listening
that's kind of
to
1 in 4, I suppose. Yeah, so it's higher than maybe you think.
Yeah. So some of the people listening to this will need the support of medical colleagues.
Yeah, absolutely.
In interacting with medical colleagues in that context,
yes.
Is there anything you'd say?
Yeah. I mean, inevitably things happen there because you're going to go into a different environment, away from your home environment, but you might already be in hospital, I guess. But if you're in a midwifery unit, usually there's quite an attention to the environment,
right.
and there's a strong relationship with carers. What I would say is, there may be a number of decisions that need to be made. It's unusual for that to happen immediately or really needed emergency kind of thing. That's actually, people sometimes misread labour like that. They think, anything that happens that's wrong kind of is an emergency. No, it isn't actually. Most of them, there's a bit of time to think it through a bit. So you've got some choices that are still there. You certainly would request to be fully informed of what's going on and if there are any risks associated with any procedures, that kind of stuff. As a partner, I would say, just be aware of that because you can be a kind of beside assertive presence there.
Yeah.
That can help with that interface.
An advocate.
Yeah, an advocate.
Support.
Yeah.
I think it pays us to remember that she's the boss, right?
Yeah. Absolutely. Yeah. That's
Most
right.
of us are painfully aware of that anyway.
Yeah, and it's her body that's going through this.
Yeah.
But I've just seen it in the past where sometimes the medical things tended to dominate. And
Yeah.
you don't want that happening when you've had a nice experience that's been you've been leading on it yourself. You know, you want to retain some sense of control and choices, even though other things might be needed here. So.
Yeah, and it's helpful to bear in mind that our medical colleagues are coming from a place where they value the experience that you're having.
Yeah.
Thanks. A lot of men hear about stages of labour and all of that kind of stuff.
Yeah.
What are the stages of the birthing process? And is there any way that a partner would know that she's progressing through them?
Yeah. Well, a lot of women will read about this in advance of labour, and more than anything, they're helping themselves understand the language that their carers are going to be using. Midwives are going to use. So midwives talk about stages of labour. I mean, you have to remember it's a continuous process. So the stages are artificial in one sense. So you've got the start of labour. It's kind of roughly this period while the neck of the womb is dilating up, because it's got to dilate and open up completely before the baby can come out. That part is the midwives and others call it the second stage, which is a expulsive phase, where the baby's moving down through the vagina and coming out. So that phase is usually a shorter period of time, between minutes to hours, but nothing past 5-6 hours or something like that. So that's a definite marker. That has kind of physiological manifestations that are easier to spot, because a lot of women will vocalise like a pushing kind of feeling they're getting, and they're
almost a grunting
sound, and they're using muscles to help push, rather like you might if you were constipated on a toilet or sort of that kind of thing. And then the birth of the baby happens, so that's really obvious that that's happening, because you can see it clearly. Of course, the first stage is, as it's understood, the early part of the labour is a little bit harder because it's fairly different from woman to woman, and especially in your first birth, which is an unknown, you're kind of just learning as you go with that one, thinking, what's my body doing here? Really, it's just trying to support the partner through whatever she experiences as she goes through that.
Right. I
mean, typically, the contractions are supposed to get, and generally do get, kind of stronger and a little bit closer together. So, you know, when you're in kind of full labour, something like every 2 or 3 minutes, and you're getting a contraction that might last up to a minute and so on. But these are sort of ballparkish figures. But yeah, so the role there is just supporting, and that part of the labour can be quite long. You know, if you take it from when you're first getting signs of labour starting, it could be 2-3 days.
Right.
Yeah, it could be even that long, because you might be getting on and off contractions. Yeah. You know.
There are some strange words that crop up. Show.
Yeah. These are things that midwives and obstetricians read about and talk about. So show is basically like a jelly-like substance that comes out of the vagina. It's usually got a bit of blood in it. It's almost like a little bit of a plug that's at the entrance of the womb, and as the womb opens up, they call it the cervix, it kind of falls out the vagina.
Right.
Yeah, so that can happen, but it doesn't mean labour started. It just
doesn't it?
No, it doesn't mean labour started. It just means the body's getting ready.
Right, so you could have a show, and then the labour or birthing process could be several days after.
Yeah, several days after.
A lot of men talk about woman starts to have pains or tightenings, and they just go off.
Yeah.
So what's going on there?
Yeah, it's kind of like as I was saying before, it varies so much between women, but that's much more noticeable in first births, I think.
Right.
It's almost like the body just trying to get to know how its pattern is of labouring. So, yeah, it comes and goes and starts and stops. And that's why I say it can go on for several days, actually. Right. So it's just having a bit of an awareness of that and not getting alarmed.
Cool.
there's a little bit of a paradox with first birth, because that's the time most women and partners are most anxious. But it's also the time where the labour's going to be slightly longer, or usually longer, than second or third babies.
So how do they decide if they're planning a hospital birth or even a home birth, when do they decide to contact the hospital or the midwife?
I mean, it's a really tricky thing to answer in a definitive way.
I know.
So if you've got a lot of concern, a lot of anxiety, and you're just really uncertain, of course, because then the midwife, can either speak to you on the phone or come and see you and get a sense from her professional perspective, and then give you some feedback about how she thinks it's going. So beyond that, I mean, typically contractions kind of if they're less than every 4 or 5 minutes and they're, a couple of minutes apart, that sounds as though you're heading towards quite strong labour. So you can use that.
Yeah.
I mean, the water's breaking is not an absolute sign in itself. That's what the midwives will say, the membrane's breaking, the water coming away that surrounds the baby. That can happen at any time, really.
Right.
More normally it happens later, actually, but it can happen at the start of labour as well. So that isn't a necessary reason to go into hospital either. My advice, probably going to come on to this, is just do some prep work around managing that phase of the labour, and that will, as you go to education around that, you'll get lots of tips about what you might expect, what can happen, and you can build some strategies for it as well, because they often need practice in advance.
I've heard people say that the place for a woman to be when she's in this early phase of the labour is the place where she feels most comfortable and safe, where she's protected to a certain extent from feelings of fear around that.
Yeah, absolutely. That's absolutely true. But it's quite difficult for women, because the ideal model would be to have a professional on call who could come and see you at home. But across the country, there's not many places that offer that. Yeah. So a lot of the time it's a telephone conversation you're having. People feel more relaxed at home, but if they get anxious,
then it's not the place for them.
No, that's right.
Yeah.
And then if you get into a hospital, the midwives kind of discourage coming in too early, because basically in a hospital, and if it goes on for hours and hours and hours, they don't really want you on a labour ward if you're not.
No.
So then you're kind of just hanging around the place, and that's a bit dull and boring. And these days wards where you might be are really very busy, and there's not a lot of people to be there with you. So it's a tricky one, that one.
It's cool. It's very good. Right, still on the kind of questions that tend to come up. You're a man who's found out she's going to have a baby that you're going to be fathering. Lots of questions come up. Here's one. What is the best position for the baby to be in before the birthing process starts, and how can you support your partner to help make that happen?
Yeah. I mean, it's an area that there's not a huge amount of research. So most of the research on position is related to the labour event itself.
Right.
But there's kind of physiological principles that you could think about that make a lot of sense. So any upright sort of posture, basically, any posture where the mother's a little bit straight back, leaning slightly forward. So like a little bit of, because the pelvis has got a bit of a tip in it. And if you're doing a lot of reclining postures, the baby's going to fall away from the birth canal a little bit.
When you say fall away?
Well, it's floating in the water in the womb, and when you lie back, it's tipped towards the stomach.
Ah.
Yeah, that way, rather than towards the vagina.
Yeah.
Be explicit about the anatomy. So
call it what it is, Dennis.
So encouraging upright posture in late pregnancy. It's difficult because we're in a culture where reclining posture is the rest posture that we take up, even sitting in a car. So that's a bit different to the past, where we think people have much straighter backs, they're doing more manual work, they're off there.
Scrubbing floors.
Yeah, all that kind of stuff. Or even just working in the fields, probably. So there's not a lot of evidence for that, but that makes a lot of sense, common sense.
Almost makes mechanical sense.
Yeah, it makes mechanical sense as well.
A biomechanical sense.
Yeah,
I remember when I was working as a community midwife full time,
Yes.
used to kind of gently encourage women at a
Yes.
certain gestation to crawl up the stairs once a day.
Yeah, that sort of thing.
Yeah.
Yeah. So that just makes common sense. So it's a good thing to do in the run up to labour.
Encourages
Last
the
weeks.
baby's head to potentially come down.
Come down. Yeah.
A man's partner is coming towards term.
Yep.
Say something about due date.
Yeah.
Because what does that mean?
Yeah, it's kind of misleading because pregnancies, something like 99% of babies, women go into labour between 37 and 42 weeks.
Oh, right, so it's a period.
Yeah, it's over a 5-week period. The due date is actually not that common to birth on it. I think the stats say around 10% or less.
Yeah, I read somewhere that a woman having the
birth
first baby, 80% are likely to go over. So-called due date.
Yeah, that's right. So it becomes misleading in that sense because inevitably people put it as a marker in the calendar and sort of operate towards that. And then when you don't go into labour, there's a kind of thing about just waiting after that and everyone's on your case ringing up and all of that sort
Obvious
of stuff.
in a way. If you've got a due date, the day after, you're overdue, right?
Yeah, that's right. Yeah, so they're not saying, if you like, is that there's a space where babies come that's about over a 5-week period.
Right.
A couple of countries, I think France is one, has moved it back a week or something like that.
Yeah, I read that.
Yeah, just to try and deal with that problem of anxiety post the due date.
Right.
So, yeah, it's a tricky one. I know some women have secretly given out to friends and family a 2-week later.
Yeah.
Just so they won't have people ringing them up all the time.
Yeah.
We did some research recently on this and it was a real pressure for women. They were saying everyone's ringing, texting, every day, and I'm just getting sick of it.
Yeah. Maybe it would be a good idea to get rid of due date altogether and be speaking about a due period.
Yeah, that's right. Yeah.
So when is a woman overdue then?
Well, it's kind of interesting because the goalposts on that have changed in the 30 years I've been practicing. So I remember when I first started that some people didn't even believe in being overdue. We had a doctor, an obstetrician actually, who just let women go on and on.
Oh, Nick Nafton.
Yeah, you remember.
Yeah.
But even then it was about 42 weeks, so I'm going back to 85, 86, but now it's heading towards 41 weeks. And the reason for that is obstetrics has a view that there's a tiny increase in risk of a baby dying in the womb after 41 weeks. But it's a tiny, tiny risk, and it's actually quite difficult to even quantify it, but it's probably less than 1 in 1,000,
right?
Something like that. So what you must understand, I guess, is that if you go to the due date and then go 7, 8, 9, 10 days, you're not falling off a cliff when you move from day 10 to day 11. It just means there's a tiny, tiny increase in risk.
Yeah.
So you need to think through that a bit, because if you do have an induction, which is what the service calls it when a woman is overdue, then there's other things that go with that, like a prolonged period of trying to get you into labour that could last 1 to 2 days. The chances that your contractions are going to be much more potent and powerful. There's an association with a lot more drugs in labour and birth because of an induction, just because it's something you've artificially started. It's not a natural process. So it's weighing those things up. So
is there more? I don't think there's necessarily statistically more chances of a caesarean section with induction.
No,
I don't think that's been shown to be a close correlation.
Yeah.
But I guess there is a slight increase in chance of needing help with the birth in terms of the sucker, the Von-2s and
forceps thing. And that's related to epidural use. So women who are induced have far more epidurals, and epidurals have an impact on the birth itself by requiring more assisted birth.
I think the national rate of epidurals is roughly about 35%.
Yeah, that's covering.
You mentioned that induction of labour is trying to start a physiological, natural process,
yeah.
and we don't really know why the birthing process starts in the way that it does.
Yeah.
Of course, there's all kinds of tales you hear, Dennis, like castor oil, is it rose slip tea? There's all various. Now, can you offer any support for a couple? Let's assume the birthing let's assume that the pregnancy has gone on, edging towards 42 weeks.
Yeah.
All right. Is there anything that we could be offering as support for encouraging that natural process to start?
I mean, the research is very unclear on benefits there, but if I was going to do anything, I'd probably explore some of the complementary therapies.
Right.
Because they are very safe because they don't involve ingesting potent drugs.
Yeah.
They tend to work with physiological processes.
Yeah.
If you have a belief, so for example, you've used some of those therapies in the rest of your life,
right,
then just having a belief around their usefulness is quite good.
Right, yeah.
That sometimes can work, can help facilitate it. There's the old one of using sex.
Oh, yeah.
Yeah, so having more sexual intercourse with the male semen.
Yeah.
It contains something called prostaglandin that we know is part of a process of starting labour.
Yeah.
Now, I can't tell you that, 5 episodes of sex are going to deliver this boost, but it's not going to be an issue. And
and the prostaglandin in sperm is of a different nature, and I know we used to say there might be some kind of friction at the cervix from penetration, and when the cervix stimulated, it might release prostaglandin. It depends on how long your dick is, I suppose. I did read somewhere that a piece of research that says that the semen is best absorbed through the oral mucosa, which is definitely research done by men, Dennis.
Yeah, that's right.
Although I have heard at least one obstetrician, Michelle Adont, suggests that the hormones responsible for female of our species releasing themselves into orgasm is the same family of hormones responsible for birth. Yeah. And that orgasm or sexual arousal and birth are one event separated by time.
Yeah.
That suggests that a penis might not be necessary in order for her to release herself.
Sort of like female masturbation.
Yeah, to release herself into orgasm.
Yeah.
That arousal response might be as good a way as any as facilitating the start of the process. Would you concur?
I mean, I've never seen any data on that, but it makes, again, it's back to this thing about making physiological sense.
Yeah.
There is a link between, I think a more obvious link between orgasm and birthing, just because in the second stage it's kind of like an ejection thing that people talk about. So you can kind of see that more directly. But, why not masturbate if it's going to help you go into labour? I can't see a downside.
Well, I've looked after women that have chosen to masturbate while they're in labour, in the birthing process.
Same kind of thing.
And, of course, there was the Kinsley report way back in the 70s that was investigating a sexual response and found that the cervix and the uterus of a woman make an expelling motion when a woman is aroused, which fits completely with this idea.
Rhythmic contraction.
So you spoke about alternative therapies.
Yes.
Did you have any in mind?
Yeah, I'm just trying to think of the one that you burn. What's it called again?
Oh,
moxibustion.
Yeah.
So moxibustion. There's a tiny bit of research on that it can help start labours. Not like big studies that have said, this works. But that, I mean, I think physical activity, walking, things like that are all going to help because it helps the baby, move into the pelvis. Yeah. But, I mean, other types of things like acupressure, acupuncture, shiatsu, uses this kind of alternative trigger for physiological process through meridian lines and points on the outside of the skin. And, I think all of those are fine to try. Yeah. Absolutely.
And they may not have a research base, that they might have years of traditional practice and
behind
experience.
Them. Yeah. And they're not going to be harmful.
Cool. Okay, Dennis. Lots of options and choices out there regarding how a woman manages her experience of labour or the birthing process.
Yeah.
You know, whether that occurs to her as pain or otherwise. If the man's partner is experiencing, discomfort through the birthing process, what is available to help to support with that?
For the man.
Well, no, not for him.
Yeah, for her. We're not so good at that part of it, I don't think, but we need to get better at that.
Yeah.
I mean, what is available? I mean, the prep side of it, which we've just talked about, is really critical here because that's going to give you some tools to help. But there's a whole range of complementary therapies that got an emerging evidence base. I mean, I would really seriously, unless you're completely opposed to it, I'd really seriously examine the possibility of water.
Yeah.
Because water has got, this is water immersion, so getting into a big pool, it's got so many things about it that ticks assisting physiology of birth. It's really got loads of stuff there that we're realising more and more. I find it quite interesting because I work in a system where there's kind of, the drugs, the alternative therapies, and that's it. And it's not there's a competition between epidurals and water birth or something like that. People construct it a bit in that way.
Yeah.
In a way, because of what I've seen in midwifery units and home birth, there's water immersion. It's not as effective in taking away all pain, but it's a really strong alternative to an epidural because of all that it does around physiology that epidural doesn't do because it has some negative impacts. So, really look and examine the notion of getting into water. You don't have to birth in it.
No.
A lot of women do because they don't want to get out of it once they get in. But it's just a brilliant... And it needs to be in a pool scenario where it's deeper.
Yeah.
Yeah. So I'd absolutely look at that because, as I said, really good evidence that it reduces the need for other drugs, epidurals and so on. But there's a range of other complementary therapies. There's, naming them all off would be something. But in terms of evidence, acupuncture actually has got a pretty good evidence base. Things like water and acupuncture also tend to make the labour shorter, so there's other little advantages that come in there. But there's a range of other complementary therapies. Anything that hits the kind of relaxation...
Like hypnobirthing?
Yeah, hypnobirthing, aromatherapy, mindfulness, we could go into loads of them here, actually. Good. I mean, obviously, if drugs are your preference or indicated because of what else is going on, there's a number of those. One of them is gas and air. Yeah. It's really, really common in the UK setting.
Entonox, I think it's
Entonox, that's right. It's a mixture of nitrous oxide and oxygen. It has the advantage of getting out of your system pretty quickly, so when you use it, it kind of works over the minutes, but then its effect wears off a little bit till the next contraction, that kind of thing. It's not as invasive. You're breathing the thing in through the mouthpiece.
Doesn't cross the placenta, so it
doesn't affect the baby. It's not an injection. You're not putting it into your bloodstream like a lot of other drugs end up working in that way.
You get the timing as well, don't you?
Yeah, and you regulate it yourself. Yeah. So that's good. I mean, other drugs that are used, there's still a role for what's called morphine or pethidine. Yes. Which is an injection. But they're not that effective. No. And they do have side effects that they can cross over to the baby. You were mentioning that before.
Yeah. And the baby can be born quite sleepy.
A bit sleepy, yeah.
And in very few cases need an antidote.
Yeah, that's right, yeah. I mean, most anaesthetists, of course, will straight away suggest to you an epidural. Yeah. Because that's the way they go. To remember about an epidural, it's effective in all the studies as taking away most of the pain. But there's actually 15% of all women who have them who don't get total pain relief.
15%?
Yeah, as high as that, And often, sometimes that name may not be told. It's not a panacea in that sense.
And there is a very small chance of quite a severe headache after an epidural. Yeah, it's kind of and an even smaller chance of other
really
more major
serious stuff. Yeah, that's right. But the main thing to think about with an epidural, in my view, is its impact on the pushing phase of labour, the last part. And you need to consider that a bit because you're going to, we know that the assisted vaginal birth, I mentioned earlier about the suction and the forceps, these go up by a third.
A third?
A third.
In the context of an epidural?
Epidural.
Okay.
And in first birth, it might even be more than that.
Right.
So it's worth thinking about that, because that's not a great
No.
birth experience often.
What about TENS? Whatever that is.
Yeah, that's kind of a little bit non-invasive, that one. It's a stimulus to the
Is
outside
it
of the skin.
trans-subcutaneal?
Yeah, nerve stimulation.
Yeah.
Again, it enhances physiological processes.
Yeah.
It doesn't have side effects. It's self-regulated.
Yeah.
So yeah, that's worth.
And he can put it on.
Yeah, he can put it on. You can't use it in water.
Well, not on himself.
Yeah. Yeah, but yeah, it's kind of one of the least invasive ones.
And anecdotally, I used to say to couples, get hold of it at 35 weeks.
Yeah.
Practice putting it on.
Yeah.
And I observed that women that have practiced putting it on and tolerating it as high as they could in their practice, so that when the birthing process started, they could put it on and they could get it cranked up.
Get into the groove. Yeah.
Certainly seen it be very effective up to around about 8.5 centimetres, funny enough.
Yeah.
So all anecdotal.
Yeah.
You know.
Yeah.
But, worth a shot.
Yeah,
And you can hire them, or you buy them for 35 quid.
Yeah. Absolutely, yeah. And I would recommend those in the sort of options before you go down the drug route.
Brilliant. And then thinking about environment in terms of maybe, dimming the lights.
Yeah, that's the thing about
maintaining privacy.
Yeah, not disturbing people.
Allowing a woman to lose herself if she appears to be not wanting to talk.
That. And that ties in with the physiology, etc. Yeah.
What about symptometrin? What about the term that I've heard, active third stage?
Yeah.
What are the choices?
In summary, the service recommends what they call active management because of a reduction in bleeding. One of the risks in third stage is bleeding.
When we say third stage, we mean the birth of the placenta
comes out. Yeah, that part. So it's the bit that happens after the baby's out, obviously. But to be honest, because living standards and all of that, especially in high-income countries, have improved so dramatically, actually I don't think that risk is there for women who are having normal labours and birth.
Right.
So what you see in midwifery units and home birth now is entirely physiological, all the phases of stages.
So
whatever.
No symptometrin?
No symptometrin at all, no drugs at the end of the birth, no.
Right.
And safe. The research, I've actually got research that says that's safe.
Right.
Now, there aren't that many randomised controlled trials, the gold standard of evidence, but there's some really large population studies that show it's not an issue. So for me, you only give a drug if there's a problem.
Right.
So why would you
give it just in case?
Just in case, yeah. And it has other impacts as well.
And so you're suggesting that physiological third stage, given the absence of other pathology or problems,
safe and
is a safe thing to do. And good for the baby?
Yeah, absolutely, because of the delayed cord clamping and things. And in a way, I want to probably stop using the word safe. Why would it be set up to be unsafe from an evolutionary perspective? I don't know, that doesn't make any sense. So the justification needs to be the giving. You've got to find a reason to give it.
Oh, right.
Not the other way round, a reason not to give it.
So from your perspective, there would need to be a reason to give the symptometrin.
Yeah. Otherwise, the default position would be just let...
in the absence of a reason,
just let nature take
it's just
course.
The way we've been birthing the placenta.
Yeah.
I think it's worth saying that the hormone that we talk about, oxytocin, it's very important that a woman is swimming in oxytocin for the birth of the placenta.
Yeah, absolutely.
When the baby's out, that's not a time to be fuffling around and doing loads of stuff, but to keep the environment such.
Absolutely. Yeah.
Thanks for your time today, Dennis.
Yeah,
really appreciate that.
No problem.